Good to see a big crowd here today. Good to see Roz all the way from the other side of the country, and where's Simon from the other side of the pond, the big pond. It was a great talk earlier, thanks. So look, I can cut through these first couple of slides very quickly. So Simon's gone through this. So just a reminder for those of you that may not have been here earlier in the day, a current PET scanner, or a typical generation PET scanner, starts with the head, and it works its way down in a series of steps. The axial detectors are around about 20 centimetres, so that's a process that takes around about 25 to 30 minutes. With a long axial field of view or total body PET, you can do all of that in one go. So the unit that Simon was involved in is 2 metres long. The one that we've bought, Quadra, is 106 centimetres. So you are able to acquire studies in a much faster time. The quality is much higher than what we're used to. So these are digital detectors, and because you have all that extra sensitivity, given the axial field of view of 106 centimetres compared to 22, you're picking up a lot more counts. Sorry to talk physics in a room full of physicists, but the other advantage to us of all that sensitivity is that you can go with much lower doses. So that benefits our patients, but also our staff, and there are actually cost savings around it. And as we heard this morning, and I think Dale will be talking about, you can move into the world of delayed imaging. So this is the scanner we have. It's the Siemens Quadra. So 106 centimetres, is that really good enough for us? Well, the answer is yes. So in clinical PET, most patients are scanned from the vertex to the mid-thigh. So as you can see here, this is a Siemens graphic, that covers the key organs in the majority of patients. We sometimes do go down to the legs, and you could do that easily on the scanner with a flow motions where the patient goes through. But we don't routinely do that for clinical scanning. The yield is very low, so we might do it for melanoma, sarcoma, a few indications. But the vast majority of PET scans, if you do a clinical PET scan at vertex to mid-thighs. We had our first scan here in July of this year, so we've been operational around about 100 days, and we're coming up at around about 1,500 scans. So the first question we had to do, would we reduce the time or would we reduce the dose? Mightn't surprise you to know we did both. So firstly, with FDG, we used to give 250 megabecquerels. We're now down at 125 to 150 megabecquerel. Now that in itself is a saving of around about $300,000 a year. I didn't give that back to the hospital. That's been used for additional staffing. And previously we acquired over about 25 minutes. We decided to start with 10-minute acquisitions. So that allowed us to move from 30-minute scheduling to 15-minute scheduling. So basically, we're running our clinical PET service twice as fast as we used to. So the first thing that really hit us is around quality. This is a patient with lymphoma that was scanned in the first couple of days of scanning. He had a prior scan back on the MCT, so this is earlier in the year, and that's the image quality we're used to. When we shut the practice down, because we had to do a fair bit of building works, we had our patient scanned over in the private hospital using a Horizon. And again, that's what we're used to, but then we were able to get him back here for his scan, and as I say, second or third day of operation. And you could just see the difference in quality. Have a look at the brain, cord. I put a circle around a paratracheal lymph node. It just stands out so much more on this new scanner. Have a look at the liver, how much uniform it is, and the arrowed aorta and IVC compared to what we're used to before. So it's definitely a step up in terms of quality. These are transaxials of the same patient. So again, have a look at the aortic arch, the aortic wall. There's that paratracheal node, all just so much better on the total body PET, given the sensitivity that you have and the detectors compared to what we had previously. This is a patient with a neuroendocrine tumour. This is gallium dotatate PET scan, so it images somatostatin receptors. Same thing. This is the scan that he had here on the MCT scan at the end of last year. This is what it looked like on the new scanner. So again, much better image quality. Have a look at all those nodes there. That liver lesion really stands out. Liver much more uniform. These are peritoneal nodes and nodules, which were there before, but they stand out much better. And have a look at these are all actually physiological inguinal nodes, which really are much more impressive and much easier to see. When I looked at this particular image, it reminded me of, and I was interested in Simon's astronomical background. So this is the picture that came to my head. I think for years we've been looking at patients, like looking at the night sky in the backyard in the suburbs. But where we are now, we're heading out to the outback where there's no light pollution. All this stuff was there. We're now finally seeing it for the first time. So I think it's just shows you the massive improvement in image quality that we're dealing with. No more astronomical slides, Simon. And so this is the, again, just some transaxials there. There's that liver lesion. We never caught that on the first scan with the MCT. So with the Quadra, it stands out completely. And similarly, you can see there's a sclerotic lesion on the right. which we just didn't pick. We didn't pick it at all on the scan from last year, stands out. So look, I think it's fair to say, as all our reporters have been looking at these scans day after day, I hear this. So it's certainly a big improvement over where we've been. The operating concept that we're running, it's a 50-50 joint venture between USyd and Northern Sydney. USyd have put, particularly via NIF, have put more money on the table. We have put $3 million from the trust fund, as well as provided building works and core staffing. We run the service in the morning, and the university has it in the afternoon, but conceptually that has to change around a little bit. But we do our clinical service in the morning and our research in the afternoon. It is the only PET CT scanner at Royal North Shore, so we need to run efficiently and we need the scanner working. When USyd have time, or take over the time, we provide a technologist or two technologists to operate the scanner. Very keen no one breaks the scanner, so it's better our staff that operate it. But they'll scan the patient's acquire and then transfer the data to the university's platform. We may have a nurse, depending if it's, for instance, an FDG scan and they need blood sugars. But really that turns into the realm then of the researchers. It's the medical staff and scientific staff at Royal North Shore are not involved at this point. It's the researchers that are in there and for the research afternoons. This is our clinical schedule. So as you'll notice, there's a lot of slots in there. We scan 15, there are patients going on the scanner 15-minutely. Generally mornings, we have certain variations like FET, which is an agent for brain tumours we don't get until around lunchtime, so we have to scan into the afternoon. But it just shows you it's a busy schedule, a busy production line, and if something goes wrong, we have a problem. So the first question we had is, can we go even faster? So we started at 10 minutes. So this, I was in Copenhagen last year. The group there have been working to look at how low can you go before the diagnostic image gets affected. So they did list mode data on 10 minutes, 5 minutes, 3 minutes, 90 seconds, and so on, and looked at what point you started to miss lesions. This is their results. It's slightly complex the way they're presenting it, these statistical differences from the one from the box below. But the bottom line, 10 minutes to 6 to 3 made no difference in diagnostic yield. So they were quite confident that you could be reaching similar doses to us. You could be doing clinical scanning at 3 and 5 minutes, and that was good enough. We went through a similar, more informal exercise here where I got Kathy to, again, list mode, reconstruct at different time points using different filters and so on, and gave them to the specialists and tried to get them to work out which was which and whether any that showed something that they would, or didn't show something that they would have called. This is Florbetaben, which is a PET agent for beta amyloid. Absolutely no difference between these scans. They couldn't pick the difference at all. We did the same exercise for gallium PSMA. So again, combination there of 8 minutes and 5 minute scans. Again, no one would have reported them differently. So we have now reduced pretty much all of our PET imaging to 5 minutes and half the dose that we used to before. The thing that gives us is now flexibility. The schedule is not as tight or as crowded as it was. And look, as I say, delays do occur. They might be technical, scanner related. We might have isotope delays from Melbourne, for instance. Car accidents on the bridge, patient factors, they arrive late, they can't find a parking spot at Royal North Shore. Who would have thought that possible? I can tell who works at Royal North Shore. You know, blood sugars, if it's an FDG scan, high, difficult cannulation, things happen. So to have that little bit of extra flexibility is good. You know, our only options are to acquire faster, which we clearly can do. If we have spare activity, we can give a higher dose, it's often not lying around. But certainly where we are now, we have a lot more catch-up time should we run into delay problems. And this is really important in a single facility. I don't have 10 other PET scanners to put our patients on, like some places in the world. And it's a shared asset. So the university, if they've got research patients, they'll want to get on time. So certainly we put a bit of effort in to try and work out our mitigation strategies if we run into problems like that. And it does happen. The other thing, of course, we're now in a low dose world, which is great for, as I say, radiation exposure for patients and staff. But like one of the things that we could do is do same day PET imaging using 2 different isotopes. So like this hospital does a lot of neuroendocrine tumour diagnostics and therapy, and those patients have gallium dotatate and FDG. So they usually have to have them on separate days. So for the patients, particularly from the country, they have to stay overnight, hotel costs and so on. What we can do with this is to start the day with a low-dose gallium. So gallium-68 has a half-life of 68 minutes. They'll be impressed, I know that one. And so we could give a low dose, and then a couple of hours later we inject with FDG and a more standard dose of FDG, so we can get the whole scan done in the same day. And certainly our patients love that. Some of the concerns we thought we might run into was claustrophobia, and I just had Ros in the department and she sort of raised this issue. We've had none, and I think Dale might talk a bit more about that, but it's surprisingly well tolerated. It just has not come up as an issue. With one scanner, we need good uptime. We've had a few periods of downtime. It's a complex piece of equipment, and we're certainly working with Siemens just to make sure that anything that's preventable or parts and so on are on site or readily available. But overall, it's been pretty good. And then this concept of half-day scanning, taking what used to be done over a whole day and pushing it into the half day. We do need that flexibility if our production line slows down. And we're very grateful that the university, if they don't have research subjects on, are happy for us to encroach into the time, provided it doesn't impact their program. So that is actually a very useful backup for us if we need to use that. And as was mentioned by Simon earlier, we're looking at big data. Our computing and certainly network has been struggling with some of the file sizes. So these are all the sort of things that you just have to take on board. So look, that's an assessment of 3 months use of this scanner. Look at all these happy staff that I've got. That's always a good sign. But we've got a team of about 30, so that's medical staff, technologists, scientists, physics, radiochemistry. Look, this has been really well accepted. I think everyone really likes this scanner. The patients certainly love it. Anyone that's had a scan on the old scanner compared to this one just say that was so much better. It was so fast and so on. So I think, that it's a very expensive piece of equipment, but if there's any way you can make that happen, it's absolutely something that you want to do. So I'm going to hand over now to my partner in crime, who might expand on some of this and move into some of more the research applications. Thank you.